Thank you. So today I'm going to share with you the work we've been doing at Duke University with Tom Plasek, looking at combining elasticity imaging of the prostate with B-mode to improve the visualization of prostate cancer in ultrasound images. Perfect. We do have some disclosures, and primarily that the technologies we're showing today are not available commercially as yet. So our motivation, of course, is to provide better visualization of prostate cancer in ultrasound imaging. And if we can do that consistently, and particularly if we can be sensitive to clinically significant disease, this would improve ultrasound-targeted biopsies. It would also have the potential to improve MR fusion biopsies. It would have applications for everything we've been talking about today if we could just do a better job of visualizing the prostate cancer in ultrasound. The way that we do this is not what people may be familiar with. Many years ago, compression elastography became available with ultrasound, where you had to apply compression with the transducer. That's not what we're talking about here. What we do is we use focused ultrasound. We turn up the energy in the focused ultrasound beam. What happens then is that displaces the tissue or moves the tissue a few microns. This is a movie showing what actually happens in 3 dimensions when you have a focused ultrasound beam. And what you can see here, the transducer would be in the rectum at this image. You'd have displacements here on the central axis, and a couple things happen. You displace the tissue. Softer tissues move farther than stiffer tissues do for the same applied force. And then you also have shear waves propagating. You saw those movies of shear waves propagating out to the side. So you can quantify the displacement on axis, or you can quantify the speed of those shear waves with stiffer material having higher shear wave speeds. Let's see if this will move forward. Yep. So what we do is we take that single point interrogation, and we can do that in multiple positions along a given imaging plane. And then we've implemented this with the transrectal side-fire probe so that we can then automate, in an automated way, rotate the probe and interrogate the entire 3-dimensional volume with many, we do about 60 excitations per plane, and then we do up to 100, 150 imaging planes to get nice spatial resolution, highly sampled spatial resolution of the prostate to make our 3-dimensional images. And we can use this to screen and look for cancers, and also for targeted biopsy has been our goal. We've done this in a study in a series of patients over the years. And the first subset I'll be showing were some radical patients who've chosen to have radical prostatectomy, and then we correlate the images, the in vivo images, with the histology to see what we're seeing in the images. Here's an example. The images that we focused on initially were what we call acoustic radiation force impulse, or ARFI images, where we're just pushing and making a picture of how far things moved. What I'm showing here is a 3-dimensional view with the axial image plane. Whoops, let me go back. Sorry, with the axial image plane here, the coronal image plane here, and the sagittal image plane here. These yellow lines indicate the intersection of these imaging planes. And what we can see is that the peripheral zone, we've got really nice delineation of the anatomy of the prostate. So we can see the peripheral zone, we can see the urethra appearing softer, and then we can see the central gland appearing stiffer surrounding that urethra. And we can also see a region that is asymmetrically dark, or which didn't move as far, so it's stiffer in this image. These ARFI images, where we're just looking on axis, are showing relative differences in the response, so it's not a quantitative measure, but it's demonstrating that, in fact, we do a nice job of visualizing prostate cancer. Here was a large Gleason 6 cancer. And we can see this in multiple views. The best views are, of course, the views with left-right symmetry, and what we tend to look for is asymmetry. What we found in this study, in this analysis of 30 subjects, was when we saw dark, stiff, high contrast lesions, we had an excellent positive predictive value for clinically significant disease. As we saw lower contrast lesions, our positive predictive value went down, but still we did fairly well. We achieved 79% overall positive predictive value for clinically significant disease. And the majority of the lesions that we identified in the stiffness images were in fact cancer, just not all of them were clinically significant. Okay, since that time, We've done a lot of work working on coming up with some quantitative imaging metrics, and the technology that I'm showing here, this is that same ARFI image, but we've implemented some shear wave propagation technologies where we can quantify how fast those shear waves are moving. We're still using that high density excitation sampling that we've been using before, but now, so it's the same exact data, and from that same exact data, we can get B-mode images, we can get stiffness, RFE relative stiffness images, and we can get quantitative images. And so here you can see that in that cancer, we had a very high shear wave speed of about 4.5 meters per second. I know that number doesn't have much meaning, but it is a quantitative number that will change and that we can longitudinally monitor as it changes. The other thing that we thought was really encouraging with these images is we have really nice concordance between the shear wave speed image. Typically when you go to reconstruct, there's a lot of math and filtering involved, and sometimes you lose your resolution. But with this approach that we've taken, we can do a nice job, and we see good concordance between the structures in the shear wave speed image and in the relative ARFI image. And again, we can see the central gland looking stiffer in this image, but the peripheral zone looks softer, and our cancer here looks stiff in both images. Now, I did want to compare this. There is one commercially available shear wave imaging technology on the market. And with that system, this is reported in the literature, it's not the same case. What has happened with that system is the images tend to be much lower resolution than what we're achieving here with our side fire array. So we have a custom array that we've designed to make these kind of higher quality images here that have good concordance with our other stiffness images. So what we decided to do was come up with a multi-parametric ultrasonic imaging approach where we could combine the information from the ARFI image, the relative stiffness image, the relative stiffness image, the quantitative stiffness image, and the B-mode image. We used a support vector machine, which one was mentioned earlier. It's a simple classifier with 11-fold cross validation to figure out how we would combine all this information into a single multiparametric image where darker regions would be indicative of something suspicious for cancer. We lose some depth with our shear wave image, and we're working on that. But in any case, we've done this with data. This is a new set of patients and 15 patients. So again, these are all small number studies. And what we've seen is that the dark regions do a good job of correlating with cancer. And here's a case where we saw something dark and it was cancer. Another example of a dark multiparametric image with cancer. Here we saw this lesion here, but we missed this lesion here. So we're not perfect in any stretch of the matter. But we did do a nice job, and we did find that by combining all of the possible sources of contrast available to us from this ultrasound imaging system, we were able to do a decent job. And 83% of the clinically significant cancers that were present on histology, again with correlation with whole mount post excision, were identified by a multiparametric ultrasound imaging system. And what we're doing here, our goal is to introduce additional sources of contrast in the ultrasound image so that we would be able to do a better job of visualizing the cancer. The 3D approach we're taking is slower, but it is high resolution, and we're doing a nice job of visualizing structures within the gland, which is very confidence building. We do have some limitations in this study, but I wanted to show you where we're going next. We've got now a custom designed system, which is going to allow us, we need this side fire array to be able to get good high quality signal in our radiation force images. But we're going to be moving into doing some targeted biopsies with the system in the next year, and we hope to report on that in the future. Thank you.